Well, first she needs to do the broadcast and then record.
Okay. Oh, whatever, but.
Okay, it says it's recording.
Okay, welcome everyone. My name is Lori Williamson Dean, and I'm the Program Manager for the Heartland Genetic Services Collaborative. Thank you for joining our webinar today. We're very excited to present this information to you, and be introducing the panelists and a little bit about the Heartland and about this project. Our lead presenter today is Marianne Kaufman. Marianne is a genetic counselor by training who also worked for many years in public health genetics in Oklahoma. She has been the lead on this project since its inception, and is incredibly integral to this entire project. And she'll be presenting the bulk of the information today about the project and its findings. Let's see here. And then Marianne, will you be introducing each speaker of the panelists?
Sure, I can.
Okay.
Yes.
I don't have those in front of me. Okay. And so next slide, please, Deanna. So just a little bit of background about the Regional Genetic Service Collaboratives, and then we'll move into the project. So since 2004, HRSA, the Health Resources and Services Administration, through the Maternal Child Health Bureau Genetic Services Branch, has funded 7 regional genetics collaboratives, along with a national coordinating center and a consumer and education center. And the primary goal since the inception of these regional genetics collaboratives has been to address the maldistribution in terms of access and services related to genetics and newborn screening across the country. And so the focus has shifted with each funding cycle, starting in the early days with a focus on newborn screening, and then moving more into the life cycle. In our most recent funding cycle, which was 5 years in length and concludes next week on May 31st, we have been focusing heavily on projects that have spanned the entire 5 years, and these projects are complementary, but we maintained them as distinct projects so that we could learn in depth about particular topics. And these topics all will eventually feed into better coordinated care for people with genetic conditions. One of the projects is the one we're hearing about today, the Hispanic Access Project. This project was really born out of a clinical problem. And the problem, as identified by Dr. Klaus Warenga, who could not be on the call today, but is a co-project director for the Regional Genetics Collaborative, what he was seeing is that in Oklahoma, at least in his clinic, the numbers of referrals of Hispanic children did not match the increased growth of the population. Moreover, when he did have children who were referred, they seemed to be referred later than a non-Hispanic counterpart for the same indication. And also, despite the discrepancy between the number of referrals expected given the increase in the population, there was still, in fact, an overall increase in the clinic. And so there was an increasing burden, if you will, to provide interpreter services and appropriate, culturally appropriate care for these patients. So he saw this as a problem as a clinician. He brought it to the Heartland to address, and then I turned to Marianne to look into this, and I'll let her tell the rest of the story, which is what the webinar is all about. Marianne, I'm going to turn it over to you.
Thank you, Lori. Next slide, please.
It's slow.
It's slow. Lori already introduced the Hispanic Access Project to you all, and it's been a wonderful opportunity for me able to work with Heartland and other regions in this project. Today, I will give a 30-minute presentation, and we have we have 3 other panelists who will be presenting, and that is Jean Halford, Erica Herrera, and Jennifer Roberts towards the end, and I will introduce them a little more formally as we progress. Next slide, please. So a very important question, other than what Lori mentioned, is why has Heartland prioritized services to the Hispanic population? And the answer is in this slide. Basically, we've had an incredible increase in the Hispanic population compared to the national increase. Between 2000 and 2014, nationwide, the Hispanic population increased 50%, but in our region of our states, it increased by 93%. And basically, the increase was due to new immigrants. So, next slide, please. So based on the information and concerns of Heartland and the increase in the population, we ask 2 questions. What are the barriers for Hispanic families to accessing genetic services? And what can genetic services providers do to provide culturally competent quality care for Hispanic patients? And I'm very happy to say that we have started, or we are beginning now to answer these 2 questions through this presentation. Next slide, please. So I think we spent a lot of time brainstorming and thinking what our approach should be. And from the beginning, we as Heartland staff decided that we need to start by going into the community, by building community. So the first thing we did is we had informal conversation with key informants in the Hispanic community from Arkansas, Kansas, Oklahoma, and Nebraska. And after that, we designed a qualitative research study by interviewing about 26 families from the Hispanic community who are caregivers of a child with a genetic condition. And the third thing that we did, which is just as important, is in the last year, we established an Hispanic advisory committee with representation again from the community to advise Heartland on the results and recommendations of the research study. Next. So this presentation is about what we learned. First and most important, what we learned from the families that were interviewed from the results of our research. Next slide, please. And the second is what we learned from our Hispanic Access Advisory Committee, which basically have members from all sorts of different backgrounds, including parents, early intervention, representation of Genetic Alliance, and genetic service providers. Next slide. I think, though, it's very important to pause to review with you all the families that we interviewed, because it very much is a very good representation of the new immigrant in our region. We recruited the families through community Hispanic coordinators and health professionals, not through genetic service providers. We recruited families that their primary language is Spanish, which usually are new immigrants. The countries of origin is mostly from Mexico, 2 from Guatemala, and 1 from Colombia. They're of lower socioeconomic level. Most parents are undocumented. All children were U.S. citizens except for 1. And the genetic conditions really very much vary, anywhere from Down syndrome to tetrasomia 18p, muscular dystrophy, DiGeorge, etc. So this is the population or the group of families that we interviewed. We actually went into their homes, into the local libraries, into the parent-to-parent family network buildings to interview, and traveled to all of these 3 states in Oklahoma, Kansas, and Nebraska. Next. So today we're presenting some practical tips that can be used in your clinical practice based on our research results, our hack discussions, and other resources in the literature. We will go through each one of these questions. Next. So the first question that we address or basically are trying to answer is, what are the Hispanic cultural norms about relationships? And what we found in our research, and very much verified in the literature, is that Hispanic families value relationships, personalized care, and respect for authority. This next quote cannot say it more clearly, and this is from one of our transcripts of one of our Oklahoma mothers. In our culture, we are very physical. We like to be greeted. We need to trust them and tell them more about what is happening with the child. They should not be putting their hand on the doorknob ready to leave or talking to the family while riding. Look him in the eye, right? And show interest and ask what the child is doing. Oh yes, greet the child many times. And when they greet our children, we feel 100%, because we are seeing that the provider has an interest in curing him, but also has a personal interest. They are interested not only in the symptoms, but they also are interested in the person. Give the mother an opportunity to speak without telling her that he, the physician, is hurried. And here's another quote that I found very telling. They only call us with their hand, come here. They don't understand us. We don't understand them. So we stay quiet. I don't know. I don't know if they understand us, how we feel. So we learned from these quotes and others very similar in many of our transcripts is that Hispanics are not as time and task oriented. They tend to be more focused on relationship. Hispanics like to be greeted in a more formal approach, especially with elders and new immigrants. Hispanics may not ask questions or complain to health professionals out of respect for authority. So we stay quiet. Next slide, please. The second theme that we identified in this category is the family's values of strong family ties, a kind of a collectivist way of approaching basically everything. This theme was not as strong, I think, in our research, but it's very much written in the literature and very accepted. One thing that we noticed in many of our transcripts is a man or a woman would say, my mother says. So Hispanics tend to be group-oriented. The family model is extended to grandparents, aunts, close friends. And decisions, including medical decisions, are usually not made by the individuals without consulting the family. Next. So what do we do with this information? What kind of tips can we derive? And we came up with 7. And this is very important because what really screams out both in our research and in the literature is the need for more personalized care. So the first tip is to greet every family member with a handshake and refer adults as señora or señora, señor or señora, or Mrs. and Mr. Greet the child and talk to child as many times as possible. Get to know the family at a more personal level, formal but friendly. Avoid body language that may suggest being impersonal, disrespectful, or hurried. Look at a family before writing. Show that you're listening through eye contact and body language. Allow time for questions from the parents and other family members that may present in the room. Allow time for the family to discuss a medical treatment or issues that they may take place in the genetic counseling session, which actually might take more than one visit. 2 common quotes that we kept on reading in our transcripts is, no me piden atención, no se preocupan. They don't pay attention to me. They don't worry about my child. So if there's one tip in this entire slide, is the need to show more personalized care, which increases trust between the provider and the family. Next, please. So the next question to answer is, how does a Hispanic family care for a child with special health care needs? And of course, the most obvious response is like everyone else. But there are some themes that we did identify that are worth discussing. The first one is that families may choose to delay or ignore medical advice. Here's a perfect quote. The doctor told me we're going to wait until 6 months to see if he can eat. But my mom said, how will he learn to eat if he's not eating? It was more about my time. I told him I cannot come here every week. So here at home, we started giving him eggs, broths, soups, everything. So then by the time they did the swallow study, they said, oh, he can eat, but make sure he does not eat too much. However, I already knew he could eat because I was feeding him all the time. Only I did not give him liquid things. This is interesting when he said that because he mentioned broths and soups. So Hispanics many times may rely more on the advice of a trusted family member or a physician from their country of origin. And there were a couple of families that actually went to Mexico or consulted their physicians in Mexico. The second theme that we identified is that some families, mostly men, expressed that the cause of their child's genetic condition is God's will. And this may be related to what Hispanics often believe, that an individual can do little to alter fate, that God determines the outcomes of illness. But this theme was not strong in our research, but it's very, very strong in the literature. And I've mostly seen it on literature related to adult chronic conditions. However, I pause a little bit because I ask how this might apply to families with genetic conditions which many, of course, consider that are not curable. So it's a theme that came up that I think demands further study, research, or conversation. Third is families may seek care from curanderos or other folk healers or use herbal remedies, antibiotics. Again, that comes out very strong in the literature. It is well known that the Mexican and other Latin American communities do use herbal remedies and antibiotics. It did not come out as strong in our research, but again, worth a mention. The next slide. Thank you. So very important. What are the tips in working with Hispanic families with special health care needs? The main tip is simply ask. Ask if family is receiving treatment from other medical doctors here or in their countries. Ask if family, if they're treating the child with herbal remedies. Ask if they're following the instructions of the physicians or feeding therapist related to foods that the child can or cannot eat. I think number 3 is a very, very important tip. Preparation and sharing of food is very important for Hispanic families. And in many of our transcripts, there seem to be several families who were feeding their child against medical advice. It's something to consider. And many of these children, maybe I'm exaggerating, but quite a few of these children also went into the emergency rooms for aspiration. And we don't know if there's a correlation, but there definitely was at least several parents who were feeding their children before the physician or the feeding therapist recommended. The fourth is regarding religious beliefs. If you sense that religious beliefs might be interfering with the care of a child, perhaps the question to ask is, will God be served by providing the best care for your child? Again, the tip is ask. Next question, please. Next slide, please. Communicate. Go back one, please. One more back. Thank you. Communication, a major and large category, and we'll have to go through this pretty quickly. But genetic and medical concepts, in addition to language barrier and literacy level, represent a challenge to interpretation. This was a big one. And these are 2 wonderful quotes. Yes, because most of the people who come here are neither doctors nor lawyers. The people that come here are modest people. For example, their father of their daughters finished grade school. If I ask for information in Spanish, they will give it to me. I will read it, and he, ex-husband, won't understand anything, even if it's in Spanish. The second quote from the same mother, well, they can give it to you, written information in Spanish. Again, we come back to that it is difficult to understand. I sometimes understand more in English than in Spanish. If they give to me in Spanish and I say, what is this word? So obviously, there is an issue in understanding concepts based on language barrier and literacy level. The second is that there is an inequitable availability of interpreters across institutions and states. And this is very important. So this quote, listen to this quote. I think it's more than Hispanics. I arrive and someone who is not Hispanic comes there at the same time as me, and they let them go through, and that person has the possibility to go, and that person can also ask, why haven't you helped me? And I can ask, and then she is helped and I remain seated because I can't say, why can't you help me? There is a lack of interpreters. This is very important because many families felt that they were being treated unfairly, which again can lead to the area of not trusting the health professionals or the clinical office. Next slide, please. Definitely, there is a wide variation among families of speaking or understanding the English language. Many of the families said, I know a little bit of English. And in reading these transcripts, I definitely felt some concern because although they may know a little English, the provider may assume that then they would understand them in English. And that can lead to a lot of miscommunication and errors. On the other side, many of the families said that a lot of the providers spoke a little Spanish, as in number 4, or that they used their smartphone. Families very much appreciated the effort, but again, it led to some concerns of errors in communicating. The fifth category, which was very surprising to all of us and pretty consistent in quite a few transcripts, is the families question the quality of translation. And this quote couldn't say it any better. They interpret very badly. I understand the doctor and I understand the interpreter, but the interpreter is not saying anything of what the doctor is saying. And there was quite a few quotes like that. Again, it creates distrust of interpretation services and affects communication between physician and the family. Errors. In fact, we had one family who did not understand the interpreter. There was some sort of miscommunication, and she left the office thinking that her child may die within 6 months, which was not correct. Next slide, please. So before I share tips with you on communication, I would like to acknowledge this document written by one of our panelists, Erica Herrera, titled Tips for Healthcare Professionals Working with Hispanic Families. In fact, I took many of her tips that I will share with you today, and she will be presenting a little bit more about this document towards the end of the presentation. Next. Next slide. Thank you. So what are the communication issues? What are the tips? And there are many, but these are the ones that we will highlight today. When using an interpreter, make eye contact with the family member, not the interpreter. There was one family that was very upset that the physician was talking to the interpreter. Direct the questions to the family member and give the interpreter time to explain. If possible, ask the family if they need an interpreter way before the appointment. If family has to wait for interpreter service, explain to family, if possible, why they have to wait, and call them into the exam room only when the interpretation services are available. Several families complained that they were having a lot of trouble controlling their child in the exam room. Only provide medical interpretation with an adult professional interpreter. And that's, I think, very important. And most institutions, especially where genetic services are available, have certified professional interpreters. Do not assume that family, and even possibly the interpreter, understand medical or genetic terms in Spanish or in English. Do not assume that families are understanding information if they nod their heads. Frequently, it just means that they are listening out of respect and not necessarily understanding the information. Consider extending your time of the clinic visit or scheduling a second appointment. Next slide. I got to move a little quicker. What genetic and other information are needed by families, and this is very pertinent to genetic services providers. Families have a lack of understanding or appreciation of the benefits of genetic services. This is a very good quote. In 2007, it was the last time that we went to genetics, and I just came back this year because my husband said, what, are they going to cure her? They're not going to do anything for the girl. They're going to prick her, draw a lot of blood, daughter will cry, and will be in the bad mood all day. Also, families do not understand or recognize the implications of genetic diagnosis. Until now, I do not know why the girl was born like this. Until now, to be honest with you, until now, I didn't even know the reason she was born like this, or what I did or what was. It's something I took or what happened. I never knew why. The doctors only asked me that if it was hereditary, but I said no, because no one in my family is like that. Next is the use of non-neutral Spanish. Makes it difficult for some Hispanic groups to understand. And I think this is pretty obvious that many times information is written by a Latino from another country that is not Mexico. And I just wanted to mention that there is a lot of literature and services that addresses health literacy for Hispanic families. And it's something that we as a region have to consider collaborating with. Next slide, please. This is an interesting one. Lack of written information in Spanish of specific genetic conditions, laboratory testing, and other. I would have to say that in our transcripts, I'm not sure if families actually verbalize the need for that. But yet, on the other hand, there was definitely lack of knowledge of mode of inheritance, sometimes a lack of knowledge of what the genetic condition was all about. And part of me wonders if this has to do maybe with literacy levels. But if you ask genetic service providers in their surveys, and speaking with personally myself with genetic counselors, they definitely identify a need to have much more written information in Spanish for genetic conditions and especially laboratory testing. Number 5 is too much information at the wrong time. I think this is an issue not only for Hispanic families, but for all families. But it was mentioned quite a bit in our transcripts, and this quote couldn't say it better. They gave me papers when he was born. Gosh, they filled the diaper bag with a lot of information because, yes, I'm telling you, they did give it to me, but my son was sick every day. Often I had him home 2 or 3 days and 1 month in the hospital. Do you think I'm going to be looking at papers? Next slide, please. So here are the tips. Description of genetic services both in writing and video from the family's perspective. This was actually kind of interesting. We could find maybe some documents describing genetic services, but not necessarily from the family's perspective. And this is something I think that Heartland will be working on very soon. And that is describing what is genetic services, what to expect from genetic service, who are the professionals, what happens before genetic services, what happens after genetic services, even if my child does not have a genetic diagnosis. And of course, one must consider a video. The next that families talked about is letters should be written in Spanish, follow-up letters. I know that in talking with Jennifer that there are many institutions that would actually translate the follow-up letters for you. And then written description or video of specific genetic conditions. Again, we go back to the video. It has to be simple and it has to be in neutral Spanish. Next question, next slide, please. This is a question, a theme that came out very strongly in our transcripts. And that is what other support information systems are needed by the families. Families learn about genetic services and other services through the Hispanic bilingual coordinators from parent-to-parent organizations. Families form strong and trusting relationships with the Hispanic coordinators. Families many times are referred to early intervention services before being referred to genetic services. Again, families form strong and trusting relationships with home visiting staff, especially the bilingual interpreters that come into their homes. Community leaders and other support groups can assist families in finding resources for the family and increase awareness of genetic services. Just want to mention real quickly, in our HAC committee, we talked a lot about the importance of community health workers, which are used many times for adult chronic conditions, also in the Hispanic population. We do need them for children with special needs. Next slide, please. So what are the tips? Form relationships, partnerships with parent-to-parent coordinators in your community by increasing their access to genetic services. This is also true with the intervention staff, the early intervention staff. And also number three, I think it's very important to provide genetic service presentations to the Hispanic community. I think all this is very important because the service providers and the community leaders provide an integral role in supporting the families and increasing access to medical and financial care. They also may have access to children and their families that the geneticist may not have access to. Many times, healthcare providers lose children or families to follow-up. And these families many times are still in the community and are continuing the relationships with the in-home or Hispanic coordinators. And also I think it's very important, and we've noticed at least with the early intervention staff, is possibly the need to increase access to the genetic service providers if they have questions, because they may have children who may have genetic conditions that they're serving and may need to contact a genetic counselor or a geneticist. Just to mention real quickly, we did implement an early intervention survey. We're now analyzing the data, but it seems what the in-home early intervention staff want is to receive training from genetic service providers on how to identify a child that might have a genetic condition. Next slide, please. So this is a very important category, and we don't have enough time to talk about it, but a question is, what may be unique about Spanish-speaking families that are not related to the questions listed above? One thing that very much caught us by surprise is families are not familiar with other health professionals other than a doctor or nurse, because in their countries they do not have genetic counselors, nurse practitioners, PAs, etc. And also in an academic setting, this may be true for all families, but they cannot tell the difference between a genetic counselor, a resident, a student. They assume that everyone is a doctor or a nurse. And so this is a great quote. Now I know they are students. At that moment, I did not know. At that moment, I believed they were all doctors. They were all nurses, but now I know they are students. Why? Because they wear their name tag. It says there. I did not know how to read it or even why they wore it. So that's a good example. Families have an expectation to receive medication or other visible interventions, and we can talk a lot about that. Families have expectation of receiving similar care in their country of origin, and that is back to the personalized care which they feel they do not receive here. Families may have a higher expectation of bilingual staff and being treated well by them. That was also very surprising to us. Some people complained that they felt they were not treated well by the first and second generation Hispanics, which is an area that I'm not sure has been addressed much. Next slide, please. And one that we must not forget, and it's extremely important, is that families have fear because of their undocumented status. And many times they have fear in accessing other medical and financial care, financial services, because obviously they're scared about deportation. We just, in our interviews, we heard stories of women with their child in the car circulating the Health Sciences Center because they saw a police car waiting until they left or finding somewhere else to park. And there's a lot of information we collected about that. and just in general, families may have more difficulty in trusting others, which also can be related to fear. And we're back again, the importance of personalized care. Next slide, please. So what may be unique about Spanish, the tips? Very important. Introduce all health professionals in the room and what they do. Explain what are the genetic services and the benefits of receiving genetic services. Train staff, including the Hispanic staff, about respectful and welcoming interactions with the Spanish-speaking new immigrant. Develop trust through personal care. Handshake. Very important. Next slide, please. So I would like to end by talking, I guess, where I began, and that is the building community. It's important to rely on tips to increase your trusting relationship, to develop a trusting relationship with the family that you're serving in the clinic. But our project began through reaching out to the community, through building community. And it turned out that at the end, after we went through our research, our analysis, our interviews, that we went back to the community informing our advisory committee. And in our last presentation, I was asked by an individual, what is the one thing that you would recommend? And my answer was back to that: reach out to the community, build partnerships with the Hispanic community. And I think it's extremely important. So know who your partners are. Next slide, please. I am currently developing a list of resources, which hopefully we'll put on the website in the next month or so. Resources that I have used and I found very helpful. So we hope to share that with you soon. Next slide, please. And I cannot leave this presentation without recognizing the families. That this, again, has been a community-based collaboration from the beginning towards the end, and we're about to start a new beginning between families, health professionals, community, Heartland, and of course the Hispanic Advisory Committee. Next slide, please. Okay, so I will stop here. Thank you for your attention. And I'd like to introduce Erika Herrera, and she is a Hispanic coordinator for the Oklahoma Family Network and another institution. Pardon me, Eric, I can't quite remember. What's the other institution?
Yes, I work for the Oklahoma Family Support 360 Center, and
okay.
It's through the Center for Learning and Leadership. We are the Oklahoma's University Center for Excellence in Developmental Disability at the University of Oklahoma Health Science Center. I'm sorry, it's a long name.
Yeah, I couldn't remember. But Erica will talk about her document a little bit about, also about trust, which is a very important aspect of understanding the Hispanic community. Erica, I'm going to give it to you.
Thank you. Well, I just want to share a little bit about the tips for healthcare professionals working with Hispanic families that I developed, and this was not per se a investigation, or it was when I started working in 2005 for the Family Support 360 Center project. It was a grant funded through the U.S. Administration on Developmental Disabilities, and it was considered a project of national significance. And I was the family coordinator. I'm a parent of a child with a genetic condition, and my child, Vanessa is her name, and I was approached by her pediatrician at OU Latino clinic to apply to help Hispanic families in this new project that they had, and also to help with do a research. And I start working with the families at the SUNY Pediatric Care Clinic. And we also will work with the residents, and each resident will have a child assigned to them for continuity of care for the next 3 years of the residency. So I was also kind of like a semi-new. My child was 24 months, so I was also learning. And the project was, very positive. It was like a study about medical home, and I started seeing. Hello? Oh, can you listen? Oh, okay.
I think yes, we can.
Okay. That's how I started writing about, what will work. First of all, I started writing something about what will work, what will not work with our, with the Hispanic families, and including myself, So some of those already Marianne already explained, but I think one of the most important ones is the trust. And like Marianne said, shaking hands and eye contact are very important to building the trust with many people in the Hispanic community. This kind of behavior is especially important when introducing yourself. Like shaking hands, not shaking hands will be considered for some bad manners in many situations. Also, one of the things, and personally being a parent of a child with genetic condition and a developmental disability, ask about the child's preferences and personality, show interest in him, on her, and also interact directly with the child to help build that relationship with the whole family. Other things also is provide also information about programs that can help the family and explain the purpose of those programs. Hispanic families members may have a different understanding about how government services operate, and they may fear that asking for services will result in negative consequences. So, sometimes you have to provide the same information, twice, Also, show the family that you are listening. Instead of writing and listening at the same time, show them you're listening to what they are saying by taking a minute to look at them before you start writing. And I just want to mention that those tips were developed, not only by me, but reviewed, but I lead a support group in Oklahoma City, and I presented those tips to many families before I did my last draft for this document, and hopefully it will help you in your clinic to better serve the Hispanic population.
Well, thank you, Erica.
You're welcome.
Okay, we will now move to Jennifer Roberts, and she is a laboratory genetic counselor at Mercy Children's Hospital. Move one more slide, please. Two more slides, actually. Yeah, the next slide again. Thank you. It's yours, Jennifer.
Okay, thanks. I actually, before I was a genetic counselor, started out as a home visitor, working with mostly Spanish-speaking families that had young children with special needs. And I also worked with a lot of new immigrant families and refugee families from multiple countries. And then I became a genetic counselor and kind of saw things from a little bit different perspective, having to, instead of going into the families' homes, the families are now coming into the clinic. So I think it's really important to focus on the whole organization, the clinic that the family is walking into. So not just looking at individual providers and their ability to build trust and relationships with a variety of families, but to look at the organization as a whole. Really, all staff that interact with families are part of the process of building trust and relationships with families. So it's really important that the whole organization has policies and a plan, and that cultural competency is seen as something that's valued, evaluated, that it's considered when you're recruiting staff, when you're hiring, because you can have, you know, great medical providers, but if your front desk staff, if your, you know, people answering phone calls, if there are issues there, the family still may not develop trust with the organization, and that can affect trust with medical providers as well. So I came up with some considerations to think about, kind of in light of all of the information that we've gathered in this project and what families have told us, and my own kind of personal, you know, ideas. When I worked as a home visitor, a lot of times I was seeing families weekly, so I developed a good relationship with them, and they would often ask me to come with them to specialty appointments for their children, you know, to make sure that they were understanding the information, to make sure that, you know, the interpreter was interpreting what the doctor said correctly, just as kind of a backup person for them. So in seeing things from that perspective, I've seen it coming in with families, you know, the things that they encounter along the way. And then I've also seen it from the other side as a genetic counselor. But really, you know, the first thing a family is going to encounter is front desk staff, and sometimes forms and paperwork that go along with checking in at a clinic. And it can be very overwhelming, especially if the forms are all in English. They're difficult to fill out. You're also trying to take care of children in a busy waiting room while filling out these forms. So I think clinics really need to think about what information they're gathering from families, what kind of support they're offering families, what the language and literacy level of families they're serving is, and if there's another way that information can be gathered. It's very important for front desk staff to have welcoming and good interactions with families, because that's going to be the first impression that a family has coming into a clinic. Also, I think it's really important that families can communicate through an interpreter or bilingual staff, not only with their medical providers, but also when they're checking in. They need to be able to give the correct information to the front desk staff. And so that means that an interpreter already needs to be with them when they're checking in, or there needs to be bilingual staff available to help them. The other important thing is training for front desk staff, to make sure that they know how to assess a family's need for interpreters if one hasn't already been requested, and then how they can access those services if needed. Another important consideration is the environment, the physical environment, for example, the waiting room, making sure that, you know, any posters, pictures, videos that are playing in the background reflect the cultural background and the languages of the families receiving services at that clinic. And that reading materials in the waiting room similarly reflect culture, language, and literacy level of the families that are being served. Next slide, please. Other things to consider, really we need to consider everyone who's interacting with the family when they come into the clinic, and that would include interpreters. Also important that interpreters arrive in a timely manner, that we don't have families, you know, left waiting in the waiting room for long periods of time. And it's very important that the interpreters clearly communicate everything that's said by the providers and everything that's said by the family, without adding anything extra. Families need to be able to schedule appointments easily. They should not be fearful about calling to schedule an appointment. They have to be able to communicate information about their child and why their child needs to be seen. And they have to be able to call in and ask questions or give updates in their primary language. Another important consideration is the amount of time that gets allotted for appointments. if a clinic is busy and time slots are limited, then really there needs to be consideration for the needs of the family and whether maybe that family should come back on another day so that they can get all of their needs met and that no one gets shortchanged. As far as written communication, I think it's really good to consider the preferred method of communication of the family. And a lot of the quotes we read about, families are not really putting a high priority on the written materials they received. So I think some families may prefer to receive most information verbally. Others will prefer written information. And I think it's good to assess, if a person prefers to be spoken to in Spanish, I think it's still good to assess after that whether they would like to receive reading materials in Spanish or English, or perhaps both. You may have multiple languages within one family, and so a family member may want a Spanish information for one family member and English written information for another. And then also as part of building trust, I think once you have started building a relationship with a family and started building trust, it's a good time to ask for feedback from the families about any of their experiences with the front desk, with scheduling, with anything related to the organization, and make sure that they understand that their feedback is valued. If you don't formally and informally assess for this information, families might keep quiet out of respect. They might not feel that they should complain or give feedback about things that didn't go smoothly. So I think it's always really a good idea to ask families about what their experiences were of every part of their clinic visit, and then use that feedback to help improve services and improve the professional development of the clinic staff.
Okay. I also want to mention real quickly, thank you, that both Jennifer and Erica have been part of our community from the beginning. They've assisted us, have partnered with us in recruiting families. We worked together with the research project, and now they're both HAC members, and they're an integral part of this project. Next will be Gene Halford, and he is the lead researcher for our project, and I'll let him kind of introduce himself. Gene?
My position is a little different than the persons who've spoken so far. As Marianne said, professionally, I'm a researcher, specifically in the area of health and intercultural communications, and not a clinical service provider. In my experience, I've worked with, I've done a lot of interviews with special populations and with different cultural groups. I entered this project really after Marianne had completed the task of informally talking to service providers and some family members. When tasked with taking an informal inquiry into something a lot more formal, a formal structured research project, we met and discussed how to go about doing that. And the first question I really asked her is, what is it, if you're interested in what the barriers are to persons from a population finding the services, accessing the services they need, what do you think, in your personal opinion, what do you think you're going to find? And Marianne said, well, I think really what the problem is, and she stated something. And I said, doing this kind of research, that's a danger. If we go into an interview, especially with minority populations or populations who tend to respect authority, and you say, and you ask questions in a certain way, you're likely going to end up with answers that support what you think is true already. And so we spent quite a lot of time designing questions and discussing how to interview in a way so that we would encourage the persons being interviewed to feel free to answer the questions in however they saw most appropriately, and not just telling us what they thought we wanted to hear. And when I say we, I mean Marianne and Anna, because I certainly didn't do the interviews. So at that point, we put together a series of questions based on the preliminary work that Marianne had done, and she and Anna set out to collect this information. Once the interviews were done, my role was really just to listen to their attempts at trying to make sense of what they heard, and I really just coached and advised while they did the actual analysis of this data. So what comes next? What we've talked about here are the results of the research project that's been conducted over about 2.5 years, and about a year's worth of analysis after that. As a researcher, what you typically do is collect some data, analyze the data, write it up in some fancy medical journal, and you're finished and move on to the next project. But that isn't really what we're after. If we're actually trying to find ways of improving care for this population, for this group of persons, then what we're really about is building trust, building relationships with providers, but also with family members from this community. So we don't end there. We attempt to continue on and build and maintain a relationship with the Hispanic community. In terms of what we do next from a research perspective, is Marianne mentioned several issues that seem to be in the literature that we didn't necessarily find in our questions that we asked in the interviews that were collected. One of which had to do with the genetics information sheets not being available in Spanish or not being appropriate for the Spanish families. We didn't specifically ask that question because A, we didn't think of it in advance, but also it just wasn't something that emerged from the conversations that took place. Other things that came up were religious issues and the use of complementary and alternative treatments and providers. We didn't ask those questions either. But hearing the kind of responses that people provided after we've listened to the interviews, gone through them over and over again for literally months, we realized there were certain things that we didn't ask. There were certain questions that remain, certain ambiguities or inconsistencies that would be interesting for us to go back and follow. Interesting academically, yes, but more to the point, interesting in terms of finding newer, perhaps better ways of improving care for the families affected. And so the next phase really, in addition to continuing the work we've already done and developing improved treatment plans for addressing this community's needs, the next work will be continuing our research, asking more questions, being more specific in certain areas, asking new questions in other areas to find out what it is we can really do to improve the health and access of this population. The new Heartland project starting in a month that Lori spoke of earlier will begin with an implementation of some new care practices. The research will continue then to see how effective those changes will be. Those changes came from the Hispanic Access Advisory Committee's recommendations based on our research. So we're looking forward to continuing the next phase of this project in those directions.
Great. Jean, thank you very much. Deanna, if you can go to the contact information slide. We're trying to extend the time for any questions. I'm not sure that we will be successful, but at least we'll put the slide on contact information with our email addresses. If you all have any questions, please do not hesitate to write us an email if we run out of time. So, Deanna, if you can unmute, we might have some time for some questions now.
Mary Ann, this is Lori, and I will just add that this webinar was recorded, and once we have the link to the recording, we will make that available publicly, because we know there were many providers who wanted to attend but could not today, and so we'll be sharing that. And Anna, where will that be listed? Will it be on our YouTube channel?
Yes, it will be directly on the YouTube channel, but it would also be available through the website and Facebook.
Perfect. Thank you. Okay. Well, there might be some time for a couple of questions, if anyone has a question.
I've unmuted everybody.
Did you unmute everybody? Okay.
Yes.
Thank you. Okay. Well, any comments before we finish the session?
Hello, this is Susan Fernbach. Can you hear me?
Yes.
Yes, I was unable to start at the very beginning of this, so I really appreciate that this will be available later. And I am in Texas, in Houston, Texas, and I really appreciate the work that you all are doing. I think it's really important, and it really gets to the heart of things. So I just wanted to thank you. I joined about 12:20, and I think this was a really impressive seminar and piece of work.
Thank you very much. Any other comments or questions? Well, we hope to continue our collaboration with you all. We appreciate your interest and your passion, what you have for this community, that we all have for this community. As Anna and Lori mentioned, we will put this webinar on many sites, which I'm not even too familiar with, and hopefully continue to share any information or services that we gather. We would love to hear from you all, any ideas that you have, any information that you can share with us. It's about working together and serving this community and other underserved communities. So thank you very much for attending this presentation.
Thank you, everyone.
Thank you.
Thank you.
Bye-bye.
Thank you.